Okay, we'll start our last session, Meet the Expert. So we'll start our talk with Dr. Mazen Khairallah. Dr. Mazen from Damascus, he graduated from the Damascus in 1987, and he got his fellowship in the internal medicine from Illinois in Chicago. He now is certified as American board since 1995, and is currently as a critical care and infectious disease consultant at Sanford Health System in Fargo, USA. He's also an associate professor at the University of North Dakota. A lot of certificates, a lot of, I hope that his talk will be very excellent. Also, he's Dr. Khairallah, work as a WHO office in Syria. He's very interested in since 2009 in the area of research is quality, safety, and management of critical care units. Okay, please, Dr. Mazen, you have the stage.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Very good selection of topics and speakers. Thank you very much for this work. It's very impressive. Yeah. And I'm going to just start by saying that whatever I'm going to present is not going to be associated with high level of evidence. We're not going to present randomized controlled trials. If there's anything, it is very poorly designed trials. Most of what we have are cohort studies, case series. So I'll present the available literature in different aspects of treatment of COVID-19. If you go to clinicaltrials.gov, you will see the registered trials that are ongoing at this point, and there are more than 300 different trials. Most of those are in Europe, China, and United States. There are only 3 trials that are completed and awaiting publication out of those trials in clinicaltrials.gov. Of course, not every single trial is registered here. And if you filter down to the ongoing trials by trials that are actively recruiting patients, you will find close to 90 different studies that are targeting different aspects of medical treatment in COVID-19. I will be talking about hydroxychloroquine, followed by remdesivir, Lopinavir, Ritonavir, Tocilizumab, and then I will touch a little bit about steroids, anticoagulation, and convalescent plasma. In regards of hydroxychloroquine, that we know that it is a heme polymerase inhibitor, but we think that it might be working in COVID-19 as a zinc ionophore. And the initial studies came from China, but those are small trials, not more than 100 patients, and showed some positive results. There's one study that is posted on Medrex IV, and we should know that those studies that are posted on this site are for preprint. Those are not peer-reviewed journal articles yet. So the authors try to seek feedback by placing their studies on this site. I see that a lot of social media are exchanging those studies among healthcare workers. So we need to know that there are major limitations to those studies. And in this study, they looked at the efficacy of hydroxychloroquine and COVID-19 in a randomized clinical trial. They included a total of 62 patients, 31 in the hydroxychloroquine, and they had 31 external controls. And they looked at the clinical improvement of pneumonia, which was found in 81% of the hydroxychloroquine arm versus 55% in the external control arm. They did not post clear statistical significance. The baseline characteristics were very deficient. The number of patients is low, and they excluded critical cases from the study. And as I said, they used external controls. So there is a big question mark about this being labeled as a randomized controlled trial, and we'll see when it is published officially what are the results of this study. What we rely on is another controversial study that was published in the International Journal of Antimicrobial Agents on March 17th, 2020. And they looked at the hydroxychloroquine and azithromycin for the treatment of COVID-19. And they looked at the virologic clearance by having daily PCR of nasopharyngeal swabs. And on day 6, they found that 70% of those patients in the hydroxychloroquine arm were having negative PCR. And in the control arm, and those are external controls, it was only 12.5% with statistical significance, indicating that hydroxychloroquine is associated with viral load reduction. Now, when they looked at those patients who were on combination of hydroxychloroquine and azithromycin, it was found that 100% of those patients had negative PCR on day number 6, and the differences among the 3 groups, of course, that now 57 in the hydroxychloroquine group, there were these differences were statistically significant, and then concluded that the effect it is more pronounced when hydroxychloroquine is combined with azithromycin. And this is their graph showing the decrease in the viral load on day number 6. It was 0 in the combination and 57% in the hydroxychloroquine alone. Another study that looked at the dosing of hydroxychloroquine and found that the inhibitory effect gets better with increasing dose of hydroxychloroquine. And they found that the chloroquine is less potent than the hydroxychloroquine. The loading dose was 400 milligrams BID, maintenance dose 200 milligrams BID. Duration of treatment was for 5 days in total, and we should pay attention to the side effects of the medication. So potential use in COVID-19 was at that time proposed to be for severe cases, but no strong data is available. It may make more sense to use it for non-severe cases. Similarly, no compelling data, but it is supply limited also, and question mark about prevention. There is a study that is completed, but we are waiting the results of this study, randomized controlled trial, but it's only 30 participants, severe pneumonia, and they were looking at the virologic clearance and mortality. So with the previous studies, we're lacking clinical outcome. We don't know if those patients did fine or not on the therapy. This one will show us mortality. There is a preprint that was sent to New England Journal of Medicine and leaked out, and shows that results are actually the other way around. They had 63 patients. This is from Wayne State University in 2 different sites. 32 patients had hydroxychloroquine versus 33 supportive care only. What they found is higher escalation of respiratory support level in the hydroxychloroquine group. So it is very much concerning. There was a trend towards worsening neutrophil to lymphocyte ratio, which is an indication of increasing severity of the disease, and there was no difference in mortality. As again, this is only submitted recently to New England Journal of Medicine. We are awaiting the peer review and the official publication, but it is concerning. There are more than 18 other trials that are available on clinicaltrials.gov looking at hydroxychloroquine and different applications in COVID-19 patients. The second medication is remdesivir. Similarly, favipiravir is another one. Remdesivir is nucleotide analog, and those medications are considered antiviral medications. There's a study that was published yesterday about the compassionate use of remdesivir for patients with severe COVID-19. They had 61 patients who received 10-day course of remdesivir, 200 milligrams IV on day number 1, followed by 10 milligrams daily for 10 days. It is a cohort study, and they looked at change in the respiratory or oxygen support. They started the study here with the number of patients in invasive being 34 patients, non-invasive, low flow oxygen and air, and room air. And they put the patients on remdesivir, and then they looked at what happened at the end of the study. So what you see here, improvement was seen in 19 patients out of total 34 patients who were on invasive mechanical ventilation or ECMO, with 56% improvement. So they had total of 53 patients on different level of supports. 30 patients were on mechanical ventilation and 4 patients were on ECMO. At the end of the study, they found that improvement in oxygen support class was seen in 68%. Patients who were extubated consisted 57% of all patients. Patients who were discharged, 47%. Overall mortality was 13%. Mortality rate in invasive mechanical ventilation was 18%, and in non-invasive oxygen support was only 5%. Again, it is observational cohort study. Measurement of efficacy will require ongoing randomized placebo-controlled trials of remdesivir therapy that is expected to finish within next few weeks, and maybe we're going to have more reports about this. So this is same results. I already presented that, and this is the graphs of improvement in clinical status of the patient with the oxygen support of the therapy. If you go to clinical trials, you will see that we have 8 different studies looking at remdesivir in different settings of COVID-19. Lopinavir, Ritonavir, it's a protease inhibitor that is used in HIV patients, and the study that is available is a Chinese study published in New England Journal of Medicine, and showed that there is no difference in terms of improvement rate between Lopinavir, Ritonavir, and control group of patients. The medication is still under investigation in different other studies. Total of 6 studies are expected to show us results in this regard. Tocilizumab is anti-interleukin 6 antibody that is specifically used in cytokine storm syndrome that was described by my good colleagues in previous presentations. And medication is very expensive. You have to have a certain criteria in order to give the medication. And we want to have at least 2 of the following. Those are all inflammatory indicators: the ferritin, the LDH, the CRP, the D-dimers, lymphocytopenia, or troponin. Medication has been studied in China, and it is approved in China in the study that is available at China XIV. This is another preprint site for those studies. They had 75% of patients who received the tocilizumab had lowered their oxygen intake. So the support by oxygen was improved. The CT scan manifestations with lung lesions, opacities were absorbed in 19 out of this 20 patients, almost 90.5%. And the lymphocytes were normalized in more than 50% of the cases. Elevated C protein decreased significantly in around 84%, but they did not report any mortality outcome. Again, if you go to clinical trials, you would see 8 other studies looking at Tocilizumab in this subset of patients with COVID-19. In terms of steroids, it is of course debatable, like any other disease with steroids. The study that is available is again on Medrex IV, and it's a Chinese study. It's a retrospective cohort with 26 patients on methylprednisolone versus 19 patients used as controls, and the medication was used in 1 to 2 milligrams per kg for 5 to 7 days. And they were looking at fever resolution and CT scan finding improvement. Again, there's no peer review yet or publication. We're waiting for this to finish, but they mentioned that mortality, this fever and CT scan findings are improved. Another study, risk factors associated with acute respiratory distress syndrome and death in patients with coronavirus. This is again from China. It is retrospective cohort study. They looked at 50 patients versus 34 patients with ARDS. They found decreased mortality, and the hazard ratio was 0.38, and 95% confidence interval was acceptable. But the number of patients is limited. This is the dissociation in terms of the survival probability. Those patients on methylprednisolone had higher survival compared to patients who were not treated with methylprednisolone. However, we know that from our previous experience with SARS-1 and MERS that those patients on steroids, they may have a higher rate of viral shedding. So we need to be very careful before we accommodate such practice. Probably we would need to wait for larger studies, but I know that it's going to be difficult to obtain those larger studies. If anything, we have to be very careful in terms of the possible increased viral shedding and possible different outcome than what we have here in this study. We have other studies waiting for publication also. They are all recruiting patients at this time, and there are a total of 5 studies that are available on clinicaltrials.gov. In terms of anticoagulation, my colleagues presented multiple studies showing that coagulation is increased in those patients, and the etiology for this is different. Of course, inflammation increases fibrinogen, and virus may induce endothelial damage on the ACE receptors. What we've seen on those patients, mainly D-dimers that is increased with fibrinogen, the PT-BTT abnormality, but most of the time platelets were not very affected. Large lung microthrombi were reported in autopsies, and there's multiple studies been published in that regard. The COVID-19 associated coagulopathy in 2 different studies. We can see here 71% of non-survivor versus 0.6% of survivors met the criteria of disseminated intravascular coagulation. So much higher rate of DIC or DIC-like picture in those patients who did not survive compared to patients who survived. In patients in another study, patients who did not survive had a much higher rate of D-dimers positive. You can see how it is separated compared to those patients who survived. That's why we use D-dimer as an indicator for progression into severe disease. And in another study showing that those patients who were on anticoagulation with heparin, they showed that the inflammatory factor that is indicated by the blue circles here is coming down compared to those patients who did not have anticoagulation. And the anticoagulation was with the low molecular weight heparin and in addition to IVIG at the same time. So this study used IVIG and low molecular weight heparin. So you can see the inflammatory markers decreasing. The T cell immunity is maintained at higher level compared to those patients who did not have the low molecular weight or the IVG, where it was declining. Similarly, the B cells in the blood were declining here. Here they were maintained at higher level. So they speculated that treatment with IVIG and low molecular weight heparin may induce some inflammatory, may decrease some inflammation in the body and increase immunity with the IVIG also. In Chinese study with anticoagulation, the sepsis-induced coagulopathy was used, and those patients who had heparin, mortality was 40%. For those patients who did not have heparin, 64%. If it was based on D-dimers above 6 upper normal limit, 32% versus 52%. But when I looked more carefully in this study, I found out that those patients did not have heparin as a prophylaxis as we do routinely on our patients. So there's a big question mark about the results of these studies. And this is what they showed here, that patients with heparin users had a better survival rate compared to patients who did not have heparin on board. What we do here is based on what the Imperial College recommended for patients, mainly for patients with D-dimers above 1,000. We give therapeutic dose enoxaparin. Convalescent plasma, which is passive immunity, it's been described in a couple of articles, one in the JAMA and the other one is the PNAS. 5 patients here and 10 patients here, and those patients showed the signs of clinical improvement in oxygenation and improvement in their CT values. In terms of the angiotensin converting enzyme inhibitors and the ARBs, there's no clear answer. Complicated, as you see. Those are the different receptors, and these are the different physiologic responses based on the stimulation of those receptors. However, what we know so far, if the patient is already on ACE inhibitor or is on ARBs, we do not stop this because we don't know if any relationship at this point, whether it is protective or it's associated with worse outcome. Most of the experts in this field feel that those patients should continue on medications unless the patient is hypotensive and there's a reason why you should stop this. At the same time, we do not start those medications for COVID-19 patients because we don't know if they are protective or not. So there are other medications that are been explored also, but we don't have much data about this, so I'm not going to present it. I hope everybody stays safe, and thank you very much.
Thank you very much, Dr. Mazen, for this very nice, illustrative, and informative lecture about the pharmacological management of the COVID-19. I will open the discussion for our friends, but before they start, I will ask a question about what is your current practice now? What medication you are giving in your center?
Well, we have agreed that we're going to use the hydroxychloroquine for severe cases only, that defined as any case that requires hospitalization. So patients with pneumonia and hypoxemia. We're using the 400 milligrams BID followed by 200 milligrams BID for 5 days. We also are combining this with azithromycin and zinc. Also, we're considering Tocilizumab for the cytokine storm syndrome. We're not using steroids or any other medications. We are enrolled in the study of remdesivir for those patients according to the criteria.
Okay, another question. Is there any contraindication between azithromycin and hydroxychloroquine about the prolongation of the QT interval? Yeah.
We are checking the baseline EKG, and we're monitoring that every 24, 48 hours to make sure that there is no exacerbated effect. If those patients had a QT interval more than 500, we will not start those medications.
Yeah, okay, thank you. I think Dr. Sharif Wadia is here.
Yes,
yeah.
Dr. Muhammad.
Welcome, Dr. Sharif. I would like
welcome.
Welcome to, I would like to invite Dr. Sharif, the professor of anesthesia and critical care and pain management at Shams University. He's a senior counselor in emergency service in Ministry of Health in Egypt, and also a board member of the Egyptian Society of Intensive Care and Trauma, and board member of the Egyptian Society of Anesthesia. Dr. Sharif is the director of the Medical Critical Care Unit in Shams University. His participation is very important for us because we'll ask him a lot of questions about our current situation in Egypt, how are managing this disaster or pandemic in Egypt.
First of all, I'd like to express my sincere sensation to be with you and all my colleagues. And it's a pleasure to me to be with you and to talk about our homework for this pandemic. Yeah. And it is very catastrophic, but we have a hope to jump out of this position. First of all, I'd like to talk about three things. First, the infrastructure of the hospitals in Egypt, the number of beds in Egypt, the number of the intensive care beds in Egypt, the number of ventilators in Egypt, and the most important thing is the number of the physicians, especially the one responsible for the emergency medicine in Egypt. And it is one of the most important things for us and one of the most problem for us. First of all, the Ministry of Health, we have around 70,000 beds. The university hospital is 35,800 beds, while the around 35,000 beds for the private sector. All of us have to know that the health service in Egypt is not a one unit, but it is military, police academy, some hospital for some minister like petroleum, Egypt Air, transportation minister, something like that, beside the Minister of Health and Population and the university hospital. Beside this, the private sector. The private sector contribute about 35 to 40% of the service in Egypt. And it differs from many parts all over the world. If we are talking about the number of beds for the intensive care units, the beds of the critical care or intensive care beds in Egypt, I'd like to talk about this. We have in the Ministry of Health around 5,300 beds. In the past, from 5 years, it was 1,800 only, without very minimal ventilators. The university hospital, around 4,800, and the other for the private sector, it's now around 5,500. So the total, it's not less than 16,000, besides military hospital, police hospital, academy hospital, and the hospital for ministers. So it is good. If we are talking about what we want for the patient, for the population, is one bed for every 7,000 population. So now we are having 17,000 and we want 13 to 14,000. So we have abandoned more than our want. So we did our homework. You can ask me why the population in Egypt are searching for the bed every day. First of all, maybe of the finance. Most of these beds are the patient himself is no one sponsored for him. Second, some of them are, we have lack of speciality. We have a lack for the pediatric ICU. We have a lack for the burn ICU. We have the lack for the fever ICU and something like that. If we are talking about the doctors, the physicians, this is the main problem for Egypt. We have in Egypt for the emergency medicine physicians, 724 physicians. It's around 24,000. But the problem, all this, the registered physicians under 6 years, active, without the resident, but the problem is 50 to 60% abroad, immigrate or in the Middle East, from 55 to 60%. This is the main problem. When we are talking about the 24,000 Egyptian physicians, we have 9,000 for general medicine and 2,700 for the pulmonology. The intensivist in Egypt, not more than 4,000. And the surprise for the emergency doctor in the emergency sector, they are 903. 60% of them abroad. And we have just 4 for the emergency medicine for pediatrics. This is maybe the problem. For the anesthesiologist, we have around 6,300 only anesthesiologists. In Egypt, we may want not at least 20,000. So we have a very limited amount of this. This is the main problem for about the ventilators, we have abundant of ventilator. There is no problem till now. Inshallah, we can go on this way to get rid of this catastrophe, inshallah. These are some numbers. If you want me to talk about our hospital for isolation now,
yes, sir, please.
Yes, we have till now 15 Minister of Health hospital open. It begins from Matruh, which is 53 bed only. But in Nigila Hospital, it's a very good hospital. Now we have 15 hospitals open in the Minister of Health and 2 only for the university hospital. One for the Ain Shams University, which is the Al-Ubur Hospital, and one El Garhi Hospital in Asyut University. And there is a plan to increase this hospital to be more than this, to be 6 for the university, and at least 20 to 25 for the government, for the Minister of Health hospital, as an isolation hospital. This is our plan for plan to be. Average of these beds in each hospital, at least 150 to 180 beds, and it is abandoned. 10 to 15% of them are intensive care, and some hospital we can increase till 40% to be an intensive care beds in this hospital. In Nigela, all the beds can be a hospital, can be intensive care beds in this hospital. The 53 beds, all of them can be intensive care. This is our plan mainly first till inshallah ما نوصلش, not to reach the outbreak stage, and we can solve it.
Sir, you know that the Facebook is full of rubbish talks, we don't know, but this will affect the general the mind of the people, and some doctors or some healthcare providers afraid from going to the isolation room, and that is it. How to send them a message about the situation? They have to be worried, or they have to be relaxed? Everything is, yeah.
For doctors, you are asking me about doctors,
Yes,
or the population?
Doctors or health, the frontline health providers,
Yes,
doctors,
yes.
nurses
The
on
health
this.
provider,
You know,
all the health,
yeah.
it is a very big job, and it's very dangerous job, and they are so. But we put for them every anything they wanted, we get it to them. But they are from the Facebook, as you said, Professor. They are heard about the number of the doctor and physician died in Europe and in the States. This is the main problem.
Yes.
But till now, it is very limited. It is very limited. It's counting one finger,
Yes.
one hand, fingers. But we are trying not to have to solve any problem for them and give them all the manifestation and all the parameters to be completely secured. And if you go to any hospital, you will be satisfied completely about this. They are separate. There is all the PPE
Yes,
with them, and everything they wanted, we get it to them. We try to get to them.
Yeah, sure.
Also,
I think
sir,
it is very important.
we are
message for
thinking
all
about
yes,
not in the main problem, not in the isolation hospital. The main problem in other hospitals.
yes,
This is the main problem, and this our
yes.
afraid,
Right.
because if we lost, this
Yes.
is the main problem for us, the medical teams. If we lost them, it will be a catastrophe, more than the patient, more than anything.
Yeah.
Our goal and our cornerstone is the doctor. And I said to them today in one of my lecture to the
Yes.
medical staff in one of the hospitals, you are the core of us. If we lose any of you, we will
Yes.
lose much. What you said that we have just in Egypt not more than 10,000 physicians, the maximum for us. So we have it is a golden.
Very, yes, sir. Yes. Sure. Any other question from the panel group?
Actually, I'd like to thank you, Prof. Sharif, for being with us actually so much. I am Ahmed Madi. Thank you so much actually for being with us. We have honored to be with us actually. Dr. Sharif, once you are the representative of the Ministry of Health and actually you are professor also at the university, I want to ask how is the integration between the different health authorities in Egypt to overcome this crisis together? You have a commission, council, health council together. How you are integrating all institutions together in this crisis management?
Yes, this is one of the most important questions, but you have to be satisfied that, and to be sure that all the ministers of health, university, and military, all they put hand to hand to be outside of this catastrophe. The hospital are integrated, and I want to tell to you that any hospital in Egypt now, isolation hospital, is consist of around 35 doctors, physicians, 25 to 30 from the Ministry of Health, and 5 to 10 from the university. They are working with each other. Each one of them, we don't know which is from the university and whom from the health minister. This is a problem, and all of us know that if we not to be integrated with each other, we will face a catastrophe for the doctors and for the population and for Egypt. There is no problem about this. The main problem is to serve and to put our doctors and the nurse team and the physician team, all the health team in a good state, away from infection, away from problems, away from anything. This is the main problem for us. Everything, if you will go to, there is no problem today till now about the ventilations in Egypt. We have a lot of ventilators.
Yeah.
Now, we have just not more than 30 patients in the intensive care today. It's no problem. But we are afraid of from the number to be from the outbreak. So we are not about how to talk to the population, how to stay alone, stay free, stay away. This is the main problem, not the integration. Don't fear about it. It will be help and it will be easy to be integrated. No problem about this.
Okay. Sir, another question, please. Another question, please, about is there any training for the doctors, for the Ministry of Health plan to train the doctors before they join the isolation hospitals?
Yes. Every hospital, there is communication by the net with each hospital for the team inside the hospital, with supervisors and consultants. This is our working inside. Our issue now is to learn the 9,000 medical team, 9,060 doctors in the in Egypt for medicine, general medicine. This is our goal, to learn them what is the intensive care. So we are making for them lectures by a professor from Ain Shams University, and we are sending for them in the NIH team of doctors and professors, and learning them on the ventilator and on the intensive care directly. First, this is the second thing. Third thing is the much more important is learning of this the nurses of this hospital, how to deal, because we have a defect in the nurses, how to deal with the infection patients, and to have how to separate themselves and separate the patient, and the porter and the secretary. All these are learning them as a team. Each day we are changing a coursing for 3 days for the doctors, for the nurses, for the paramedical, how to deal with these patients, how to deal with themselves, what they do when are returned to their home. All these are making for them, and we trying to learn the doctor inside it, inside the isolation hospital. This is our plan, and we have another plan. Once the doctors outside from the 14 days from the infectious isolated hospital, we are talking to them, what is the problem, what is the defects, what you want from us, and we solve all this.
Okay, thanks so much, Prof. Sharif. Prof. Muhammad Ibrahim. Just to sum up, I would like really to express appreciation for everyone behind this effort. Thanks, Prof. Sharif. Thanks, Prof. Thanks to Ahmed Madi. Thanks to Gindi. Thanks for all the speakers one by one. I would like to just don't want to miss any of the names sharing with us. Dr. Ahmed Haddad, Dr. Ahmed Labib, Dr. Hisham, Dr. Sameh, Dr. Ahmed, Dr. Adil Hussein. Everyone, I hope I didn't miss anybody. Dr. Ian Markham. I really appreciate all the people. I appreciate the events in the background. They did a huge job. Thank you all the sponsoring companies. And as I said in the beginning of this conference, all the sponsoring companies, we are free-handed. We didn't get anything. Every single speaker in this conference is completely here to donate that fund. That is a fundraise for the Ministry of Health Hospitals for purchase of personal protective equipment, and this is the minimum thing we can do to our country, Egypt. So I really appreciate all the efforts here. Just a couple of questions, which was like very frequently asked questions from the attendees. The first one is the certificate of CME hours. So anyone attended this conference and voted in this poll as a confirmation of his attendance. So we have more than 70% or 75% actual positive sharing in the field. So everybody is like watching up. We started with like 500 attendees. We ended up with 350 attendees, which is like integrated with us. Our delay in the program, I'd like again to thank all the attendees in this conference. And I would close here. If you would like to add anything to the course speakers or the conference speakers or moderators, please go ahead before we close.
Excuse me, sir. Can I
Yes.
say one thing? I'd like to express my appreciation to Ahmed Haddad about the video he sent it to us. It was very early, Ahmed, and all of us learned from it. And we feel that our colleague outside immigrated or outside Egypt is still with us. Thank you, Ahmed.
You have the mic, Ahmed, now. Yeah.
Thank you, Dr. Sharif. Thank you so much for this. Yeah.
Thank you, sir.
Any questions, comments? I like to appreciate this carnival of international colleagues from United Kingdom, Ireland, Australia, United States, and from Mecca or Saudi Arabia as well. Thanks very much. I hope this is not the last event joined us together. Please, the last message to all our colleagues that are home in Egypt who asked for this one through social media. They asked me to conduct such event because we have a knowledge gap, and this gap is giving them psychological pressure or tension to manage crisis with kind of some knowledge deficit. So I hope this deficit is kind of covered in the moment. And in the last message to all of them back home, please stay safe. Thanks very much. Now, thanks a million for every attendee and all.
Stay safe, everyone. Stay safe.
Stay safe.
Stay safe.
Stay safe, all of you. Thank you very much.
Thank you, sir.
all.
Stay safe.